this time in collaboration with the WFNS Peripheral Nerve Committee as well. Today we're gonna, the topic will be on brachial plexus with title of Brachial Plexus, the Fundamentals and the Cutting Edge in Anatomy and Surgery. And it's very exciting that this is part of the WFNS Neuroanatomy webinar series because there are very few more complex anatomical topic than the brachial plexus. And I think today what we want to do with that is, of course, not just demonstrate how beautiful is the anatomy of the brachial plexus, but go beyond some of the misconception that anatomy is something that is static and we all know it all. While anatomy is fundamental truth is there and hasn't changed, our understanding and our knowledge has definitely developed over time. And the way that we approach it and then care for our patients develop and improves with our better understanding of the anatomy. And today we're lucky to have probably some of the most renowned in the history of peripheral nerve surgery experts giving us talks on some beautiful topics. We have 4 speakers. We have Professor Robert Spinner from the Mayo Clinic, who is talking us about the surgical anatomy of the brachial plexus and the different pattern of injury. We have Professor Daniela Binaghi that will discuss from Germany. We discuss the radiological anatomy of the brachial plexus and some of the nuances in the imaging assessment of injury. We have Professor Nora Dengler from Germany, which will review one of the very most complex topic in the treatment of peripheral nerve, which is the thoracic outlet syndrome, and how anatomy is important in both the assessment and treatment of this pathology. And finally, we have Professor Mariano Socolovsky from Argentina, who is going to talk us about a very extremely interesting concept about the role of brain plasticity in brachial plexus injury, reconstruction, and nerve transfer. Without taking any further time from our speaker, I will hand the floor to the first speaker, Professor Spinner from Mayo Clinic. The floor is yours.
Thanks. It's a pleasure to be here with Damiano and friends to open the book about the subject of anatomy related to the brachial plexus. This is a big topic. I remember years ago, before the WFNS, spending a week doing this course in Southeast Asia. You know, the anatomy of the brachial plexus is complex, and in fact, variations are more common than normal anatomy. And you look at things like the Netter diagrams and things look so easy. And you look at atlases like David Klein's, my mentor, and all I can say is it takes a lot of practice to lay out the plexus like this. And in order to get out the entire plexus like this, you need a lot of practice on cadavers. This looks so nice because this was a thoracic outlet approach, which is easier dissection for the most part than complex injury patterns. Typically for the injury patterns that we're going to discuss, you don't lay out the entire plexus. Most people aren't dissecting out lower trunk. Here you see the entire plexus. All of these are going to be right-sided specimens, but you can see 5, 6, 7, 8, 1 in the bouncing nerve, the subclavian artery. The phrenic is the key. So really, my topic was patterns as well, so we'll talk about supraclavicular, infraclavicular, and I think you need to understand that for the supraclavicular approach, which is the workhorse of the high-speed accidents, younger patients, the most common pattern would be C5-6, which is the Erb's palsy in babies, or the panplexus. Before we even start with the anatomy, I think for patients, you really need to heighten the importance of positioning because you could make things easier or harder. And if you get the plexus at the highest point of the dissection and fold the neck back and bump up the shoulders, you really can help yourself. We don't make the big incisions typically for supraclavicular exposures. You can get what you need through a nice transverse incision centered on the external jugular vein, which is really the central point for the upper trunk. Through that type of incision and subplatysmal flaps, you can raise the dissection planes. And I think in the supraclavicular exposure, the omohyoid for me is really the key. The nerves are all below it, obviously, but if you open up the planes, both cephalad and cranially, you can expose normal and then abnormal anatomy. I spend a lot of time mobilizing the omohyoid, and then deep to that, I dissect off the fat pad and then find the phrenic nerve. I always do that first, and then I typically will find the upper trunk lateral to the anterior scalene. I'll see the phrenic and I'll stay lateral, and I usually am able to palpate that. If not, I can find the phrenic and trace that up to C5 and then work from top down. Either way. But once you find phrenic and C5, you then lay out the plexus. There are a few vessels you need to deal with. I always find suprascapular nerve off of it because that assures my anatomy. And then I obviously use my nerve stimulator to ensure that I have what I think I have. The anterior scalene is important for proximal level exposure, which is the key to most of the injuries. Here you see two different sets of diagrams. One is a little bit higher to get C5, 6, 7. The blue one would be something that Nora will talk about when she's dissecting out the lower elements for the important parts of the thoracic outlet approach. So once you have a window to the plexus, you can then further expose C5, 6, 7 at the foraminal level. Here's a case of a common pattern of upper trunk palsy, and you can see the neuroma in continuity on this specimen. Here I'm emphasizing the important role by Dr. David Klein, again, my mentor, with nerve action potentials. And after exposing this person at 6 months, this actually conducted, so I had nerve action potentials that were present, so neurolysis alone was performed. Here in a baby, and Damiano was talking about the other webinar that he's doing in a day or two, the typical pattern of the Erb's palsy is a postganglionic injury, and I think most people, or at least one common paradigm, would be resecting out the upper trunk neuroma and then doing cable grafts. Obviously, nerve transfers could also be done, but I think this would be the standard workhorse in a supraclavicular exposure. The other day, we did preganglionic C5, 6 with 7, 8, and 1 working. Here, there are many options, even though nerve grafting isn't one. Standard nerve transfers for shoulder and elbow, triple transfers, could have been done. Instead, what we did, and here again you can see the C5, 6, and 7 is divided, we used ipsilateral hemi-C7 for shoulder, and then you can see the direct repair to posterior division of upper trunk and suprascapular nerve, and then we did elbow flexion with an Oberlin procedure that we'll talk about in a moment. Now, if it works for injuries, it obviously could work for things like entrapment, and Nora will talk about that in a few minutes. But here, my hobby is tumors, and here you can see the same type of supraclavicular exposure for a lower trunk tumor. Same approach, phrenic nerve is seen at the top, 5, 6, 7, and then here's the tumor in lower trunk, nice schwannoma, open up the capsule, and there's the tumor. A few pearls. I think one important thing to know about is an accessory phrenic. The accessory phrenic needs to be respected. You can see it with the arrowhead at the bottom. This is not uncommon anatomy, and I would beg you to look for it and to preserve it. The other non-plexal element that's important in the supraclavicular exposure is the spinal accessory nerve, which obviously is a cranial nerve going to trapezius here. For nerve transfers, I tend to find it on the medial border distally, but for injuries of the spinal accessory nerve, such as after a lymph node, the key for me is finding the great auricular nerve, and I go 2 centimeters above that. And that's also a nice approach for some of the torticollis work that I am interested in. The other workhorse is the infraclavicular brachial plexus exposure. Here, the pattern is a little bit different. Instead of the younger car accident patients, these are older patients after falls or shoulder injuries or surgeries, affecting not the nerves or the trunks, but now obviously the divisions, cords, or branches. So here you can use a deltopectoral approach. This is a beautiful anatomy. Find the cephalic vein. So here you can see I'm drawing my landmarks. I'm opening the deltopectoral groove just like the Netter diagram or my own diagram, and you find the blue vein. That's a really nice landmark. You don't need to split the pectoralis. That's bloody and it's limiting. So here, once you open up that natural anatomic plane, you get into the deep fascia. The coracoid is the seat of the soul there, the muscles attached to it there. The most important muscle is the pectoralis minor. That's an important one because it's the most medial portion of the coracoid origin. Follow it to the ribs. Underneath there, there's a nice fat plad. Put your finger under the pectoralis minor. I like to dissect it and tag it because it opens things up for me. So the tags actually allow me to retract the pectoralis minor and the fat pad. So there you see my suture. Do it at the level of the tendon so you have strength for the repair. Here with the fat pad flipped over, the first thing you encounter is the lateral cord. Always be careful about the musculocutaneous and even the coracobrachialis branch. And then I always find the axillary artery just medial to it. So here's the start of the dissection. You can see the lateral cord contribution to median nerve, and then the musculocutaneous nerve. Now, if it works for trauma, it works for tumors. So here's a nice schwannoma coming out at a fascicular level, right at the level of the M, where the lateral and medial cords join. But staying with the trauma and the other nerves that you want to dissect, I roll everything medially. So I get everything in vessel loops. I tend to be pretty color-coded. So yellow's for nerves and red is for the bouncing nerve in the middle. And the axillary artery needs to be respected. And importantly, the thoracochromial branch is really important, more cephalad near the clavicle, because we can use that for a free muscle transfer. Now, to get deep to the posterior cord and axillary nerve, which are frequently injured, I take everything medially and work lateral to the lateral cord in that plane of dissection. And while you're looking deep, you always have to be careful of the superficial ones. I've seen several patients injured while other people have been working deep, and they come with biceps weakness following a typical isolated axillary nerve injury. So here, once you roll everything and you dissect deep, you can see the posterior cord, axillary nerve, radial nerve. Here's a patient where you can see I've done exactly that, and here's the axillary nerve rupture. Now, we talked about positioning. So here, obviously, I'm anterior going infraclavicular, but I have a rupture that extends into the quadrangular space. So I sensed that, so I had bumped the patient up in preparation for a posterior approach where I was getting out the axillary nerve through that interval, just like you would do for Alicia Vengvang's. And then we do an anterior-posterior pull-through technique with cable grafting from front to back. Here's another case with another axillary nerve rupture, a musculocutaneous neuroma that didn't conduct, along with a suprascapular nerve injury. We were able to do a direct repair of the suprascapular nerve. We pull through on the axillary and typical nerve grafting of the musculocutaneous, and here this patient had a nice result. Now, the clavicle is also the center of the two exposures, and occasionally you'll see a patient with a division level problem, and here you can drill off the callus after this fracture that was impeding the function of the divisions. And here's the callus under the green loop, and there it's drilled away, and we've divided the subclavius muscle. So these are the typical exposures, but all of them have natural corridors that can be extended. So the extension of these allows you to connect the dots between different portals. I think we're all familiar with the arm, which isn't really part of the brachial plexus now, but it's pivotal to our brachial plexus explorations. Many of the nerve transfers are done in the arm. There's really a very vital medial approach where through a small incision, even 2 inches, you can get out all the important structures in the arm. starting with the medial antebrachial cutaneous nerve, which could be used as a nerve graft or done as a biopsy. But all of the nerves can be seen very readily through a small incision. Here's a bigger incision, obviously showing the critical structures that we'll talk about briefly. I think the workhorse, as I mentioned and I just did with that hemi-ipsilateral C7 transfer, is the Oberlin transfer. That's really a beautiful procedure for rapid recovery of biceps. And whether or not you do a double fascicular for brachialis is up to you. We're all familiar with that approach, taking a fascicular group from the ulnar nerve just centimeters away from the end organ, as you see there. Now, the posterior approach is also a nice one that, is connected to the brachial plexus, but really is targeting terminal branches. Again, we're all familiar with the posterior approach as used for the axillary or radial nerves, and this was popularized by Li Cha-Weng, taking a triceps branch of your choice to the anterior division of the axillary nerve. Suprascapular nerve starts anterior, goes posterior. There are all sorts of pathologies and approaches, but the key is for isolated approaches to the suprascapular nerve posteriorly, as in this patient with some trauma at the level of the ligament. Very nice small approach can be used. You center your incision on the coracoid anteriorly and then dissect down through the atrophied muscle and see the pearly white ligament. Operative microscope may help you divide the ligament. There's the nerve, etc. The other obvious posterior nerve of interest is a spinal accessory nerve. With that, 15 minutes on the dot, I think that's a nice approach to a nice set of approaches in 15 minutes that I learned in a week course. Thanks.
Thank you very much. This was an outstanding talk. It's impossible, of course, to describe the entirety of peripheral nerve anatomy, brachial plexus anatomy, and brachial plexus surgery in 15 minutes. But if someone could have explained all the concept in 15 minutes, that was you, and it was stellar. Thank you. So we leave all the question and answer for the end. The co-chair of the meeting has joined, Professor Santarius, who is also the chair of the WFNS committee. One thing that I forgot at the end is to, of course, thank Professor Santarius and the team that have started this amazing initiative of the WFNS series and have including peripheral nerve surgery as part of it. I think has been it's been a very important component. And also I want to thank Professor Deborah Garozzo, that is not here, but she's the chair of the WFNS Peripheral Nerve Committee, was very supportive of this initiative as well. So I'll hand the floor to the second speaker, Professor Binaghi. So the floor is yours.
Thank you very much, and thank you very much for the invitation. Let's see if it's okay. I will talk about MRN of the brachial plexus, and I will focus on anatomy and injury assessment. I have no disclosures, and the idea today is to talk about overview about MR neurography, and we will jump directly into normal anatomy of the brachial plexus, and then we will go through the MRN findings. So what it is MR neurography? As I like to say, it's a tailor-made suit, and we will use sequences to visualize the peripheral nerves and the surrounding soft tissues. These need trained professionals and high-field MR systems. We use 1.5 Tesla and, of course, dedicated radiofrequency coils. We have a basic protocol. For sure, you already heard about it. This basic protocol depends on the region of interest and the pathology. And the general idea is to have anatomic sequences like T1, T2, and proton density, along with T2 fat-SAT sequences that will allow us to see the signal changes. In the case of trauma, we don't need gadolinium injection, but if we think the patient has a tumoral condition or an inflammatory condition, then we will use gadolinium injection. I will start with the preganglionic brachial plexus injuries. As I said, we don't need contrast media, and also we don't need to look for signal changes because we will focus on the T2 anatomy. And in this anatomy, we will see the anterior and posterior roots as linear structures. This is a T2, but I invert the window to have a better contrast. So I can see the anatomy better. So we have a crash accident, and then we need to look for the findings. We will go straight to see direct findings. That means that we will see a partial ventral avulsion in comparison to the contralateral side, and we can see also complete avulsions without the formation of the pseudomeningocele. 24 hours later, we will have muscle denervation changes, and then we will look for signal changes in the muscles. And then 2 weeks, 3 weeks in between, we will find the pseudomeningoceles. But what is very important to know is that a pseudomeningocele doesn't mean that the root is injured. So, for example, in this case, it's a baby 2 months old, and we see that the root is in continuity. So please, pseudomeningocele doesn't mean to have an avulsion. And then later on, in chronic phases, we will find intradural fibrosis, intradural scarring, and at the very end, the spinal cord displacement. And when we are in this stage, we are no longer able to say was beneath this finding. So better to have the MRI as soon as possible when we still can see the direct findings. Now, I will jump into the postganglionic brachial plexus, and that is not so simple anymore. Then we can see here 2 coronals, T2 and STIR. Then we can see the upper trunk, middle trunk, inferior trunk. We don't really see it in STIR because it has the same signal intensity as the subcutaneous path. Then we can have a sagittal view, which I think is the best view to see the plexus, and then these dots are the roots, and this is the most common variant. We have C5 and C6 going through the scalenus anterior muscle. This is the artery, and this is the medial scalene, and then we have C7, C8, and T1. This is the first rib. And then this is an oblique sagittal. Then the real sagittal view, we will still have the anterior scalene, the artery, the upper trunk, middle trunk, and inferior trunk. Then we move to the costoclavicular space. And then we still need to check the artery. This is the first rib, the clavicle. And then we will start to see the divisions. Those are the divisions anterior and posterior of the upper trunk, anterior and posterior of the middle trunk, and then is the anterior and posterior divisions of the inferior trunk. And then we move forward again to the retropectoralis minor space. And then we can see the lateral cord, posterior cord, and medial cord. And then a bit further, we see the terminal branches. We see again the artery, and then that's the median nerve, then ulnaris, radialis, and musculocutaneous and axillaris, that in this case, they look together, like if they were together. So in every space, we're able to see all parts of the brachial plexus. So that was the normal. Now we have the checklist for the pathology. We need to check the anatomy, the signal intensity, and the fascicular pattern. In the brachial plexus, it's not so easy to see the fascicular pattern, but we need to look for it anyway. We need to check the gliding tissue, the perineurial fat planes, the nerve trajectory, and of course, if it is possible, the skeletal muscles, just to check if for example, when we have neuropraxia, we will not have muscle denervation changes. And when we have axonomesis, then we will have denervation changes. And sometimes we can see brain nervation changes. And that's why it's important to check the muscles. So we will have two questions. Where is the lesion or injury located? And which is the anatomical structure that is affected? So where are we? Here we can see this is the artery, this is the anterior scalene, the median scalene. We have the dots in the back. There are two dots that are enlarged and have increased signal intensity, but it's not so easy to see. Then we go back to the image of the normal anatomy. So we are seeing these two structures there, and this is an axonomesis Sunderland 2. We have increasing intensity in C5 and C6. And this is also important to check the other sequences. We have more than one plane, and sometimes it's not so easy to understand the anatomy with just one plane. Then we have another case. This is the anterior scalene. It's very thin because this patient was already operated. This is the artery, and between C8 and T1, we have this huge scar tissue that we can also see in the coronal view. And this is a recurrent os with increased signal intensity in T1 nerve root. So again, where are we and what is affected? Then we have the T2 in sagittal and the normal images to compare. So here we see that there is no much fat tissue surrounding the nerves. We have the artery, the first rib. This is the clavicle. We have this change in signal intensity. That's because the patient had a metal place there because of a fracture. Then we can see in coronal view that the increased signal intensity is in a focal area. In a sagittal view, again, with steer, we have the images are not so nice because of the metal that the patient has. But here we see an iatrogenic injury of the anterior division of the middle trunk and a rope formation due to a screw that was going through the nerve. And then we have another case. Here is not so easy to understand because we don't have fat tissue around the nerves. We have the artery and these solid masses, and this is part of the plexus, and these two here were together the lateral and medial cord. Because the patient had a lymphoma with brachial plexus infiltration. So we can see C8 that is enlarged, and then this huge mass. Then the next is where and what again. So we have the artery here. We can see the coracoid apophyse here. And then to check with the normal images, we are placed here. So that's the median nerve. In coronal view, we are not able to see these terminal branches in a very good way, but is in the case of the tumor, we will need it to check from where to where goes the injury. This was a MPNST of the median nerve. And then the last case, this patient had a shoulder dislocation with affection of the median nerve, ulnar nerve, radial nerve. And we can see that all of them has this particular appearance with increased signal intensity. This was an axonognesis, also Sunderland grade 2. And again, the coronal view to check from where to where goes the injury. So, MRN provides a precise anatomical roadmap. That means that knowing the anatomy will definitely help you to define the strategy, because MRN will help you differentiate normal variants from pathological findings. It will also identify and characterize the nerve injuries. It will define location, extension, and severity of the lesion. And understanding these patterns will definitely guide the treatment strategy and will help you to predict the prognosis. And all of this needs teamwork. So talking about team, I would like to thank these wonderful people with whom I worked and actually work. Thank you very much for your time.
Thank you very much. That was beautiful. I mean, it was clear, beautifully illustrated. I think I speak on behalf of all peripheral nerve surgeons. We know that imaging in peripheral nerve has lag behind the brain and spinal cords. So every time we see where we are now with what you're doing and the work you're doing, it makes us amazed. And I think it's such important to be able to see this anatomy before going to the OR, and this is becoming possible because of the work you're doing. So thank you so much. So I'm now excited to pass the floor to my friend and colleague, Professor Dengler. The floor is yours.
Thank you, Damiano, for the invitation. I'm happy to join this group, and I'd like to talk to you about the neuroanatomy of the thoracic outlet syndrome for the next 15 minutes. That's Well, it became one of my favorite topics nowadays. We did quite a lot of work on that. And when I started, I did not really experience that this was a neurosurgical topic, because there are other people who are dealing with that, like vascular surgeons and some orthopedic surgeons, some plastic surgeons. However, there have always been people from our discipline who really cared for that entity. And I'm happy to join that group. I don't have any financial disclosures. I did some guideline work on other topics. And I would like to start with the anatomy of the thoracic outlet, and I don't want to double what Bob Spinner already told us. However, this may bring us into light a little bit again what structures we face when we are talking about the thoracic outlet syndrome. We are in the scalene triangle. And keep in mind that in that picture, you don't see the sternocleidomastoid muscle. We have a compression of various structures. The compression of the possible compression of the brachial plexus and or the subclavian artery. And this is happening in the posterior scalenix space, which is between the scalenus anterior and medial muscle, and below, and it's kind of a triangle, that's the first rib. And we also have an anterior scalenix space, which is formed by the scalenus anterior muscle and the sternocleidomastoid, which is not seen here in the picture on the right-hand side. However, one connection of anatomy and functional etiology is his overview on different types of thoracic outlet syndrome. Please keep in mind that we usually think of the neurogenic thoracic outlet syndrome in yellow on the left-hand side, but we also have kind of a classification into vascular thoracic outlet syndromes, which can be arterial or venous, and we even have the so-called disputed form in most of the literature parts. And here is an overview how the incidences differ. And on the right-hand side, there are the references, and you see that in most of the publications, the neurogenic thoracic outlet syndrome is the one with the highest incidence, which comes with 80 to 90% of thoracic outlet cases. However, please keep in mind that this may also rely on the type of classification that is used, and this may be different between vascular and neurosurgeons. The venous toss is quite frequent if you look into the vascular literature. And from my perspective, this is one of the most important parts of topics, is that the JAMA article that I cited below, that there is a coexistence of vascular and neurogenic compression. And this is found in 68% of cases. So usually you don't only have neurogenic symptoms, you may also have arterial symptoms or venous symptoms. So you always have to make up your mind when you are at the place. You have to look for all the structures. I think this is one of the take-home messages that I want to keep you in mind. So one major issue is the soft tissue compression. In my area, we were talking about soft tissue compression a lot. Also, this distinguished us from the vascular surgeons who usually only take out the first rib and say, okay, this has been thoracic outlet surgery. This is, in my mind, not true, and in a lot of other neurosurgical opinions too. There usually is a membrane, the suprapleural membrane. This is a part of tissue from the C7 transverse process, which runs to the first rib. And you see that you are in close contact to the cervical pleura and to the structures of the thoracic outlet. Here you see the subclavian artery, subclavian vein, but of course you also have the nerves that run there. And this serves as a kind of hypomachleon. So you always have to watch below the structures of the thoracic outlet to really make sure that there is no soft tissue compression there. So you have to have a 360-degree view. However, there's not only soft tissue compression, you also have to keep in mind that there may be bony compression, and this is a nice schematic view of different types of elongations of the C7 transverse process on the right-hand side, and below you see also a true additional cervical rib. What is a true additional cervical rib? That is then if there is an angulation between the C7 transverse process and another bony component. And it is not always true in all of the cases. So an elongated C7 process may be enough to serve as a bony compression. However, if you have a true additional cervical rib, then you see that there is another bony component in that. And we included that in a classification that a group of experienced thoracic outlet surgeons proposed. You see that on the left-hand side, we classified the neurogenic, or we subclassified the neurogenic thoracic outlet syndrome from 1 to 3. And one aspect is functional, so whether there is an functional deficit or whether there are anatomic abnormalities. And you see that in the NTOS 2, there has to be an anatomic abnormality present to make a classification in that group. And on the NTOS 3, there is no motor deficit and no anatomic abnormality visible before surgery, but the definition of the various parts concerns the pain and sensory symptoms, which may be radicular, cervical, scapular, or diffuse. So this is a subclassification used that also includes anatomic components. So what is the surgical approach? This is of a very nice paper from Eric Zager, which was published in Neurosurgery some time ago, but I think that gives a nice overview, a three-dimensional overview on the initial skin incision. This has also been shown by Rob Spinner in the first talk. However, I want to go a little bit deeper into this material. So here there is a schematic field where you see the omohyoid muscle, which is identified before as a classical supraclavicular approach. This is the one most neurosurgeons use in the case of a first presentation of a thoracic outlet syndromes. There are other options, the options from the back, which I think Annie Dupusson did a nice publication on that, which is sometimes used in recurrent thoracic outlet syndrome cases, but usually you use the subclavicular approach, and then you deal with the structures that have already been shown. The phrenic nerve, of course, the anterior scalene, the omohyoid, the sternocleidomastoid muscle. You usually do a partial anterior scalenectomy. Keep in mind that there is the phrenic nerve. Please keep that intact. What we see here in the picture is that this is looped. The phrenic nerve is looped. When I started to do thoracic outlet surgeries, I did that too. However, I left that because I sometimes find that the phrenic nerve is really something you shouldn't touch too much. So it's good when you find it. It's good if you use your stimulator if you want to find it. But I usually don't loop that anymore, because if you have a too hard grip on that, it may return, or it may go out as a phrenic nerve process. So I'm very careful with the phrenic nerve nowadays. But there's also a surgical evolution. This is a little bit more stepwise approach, which is schematic. And I think you know the incision, you know that there's the scalene fat, you know the sternocleidomastoid muscle. But there are some aspects that I want to go a little bit more detail. Please keep in mind there are two ways to find the brachial plexus. But when it comes to a resection of the first rib, and I think that differs between the surgeons. I don't use a routine first rib resection, but this is different to the vascular surgeons. They usually do that. I only do that if I really feel that there is a compression by the first rib. Again, additional ribs I do resect. But with first ribs, I only use that in rare cases. And usually you have the anatomy in women with long necks. And then you have kind of a different anatomy. And then the first rib may serve as a compressional factor, even if it's a normal anatomy from the book. But you have to put in your finger to really see whether this makes the compression or not. And keep in mind that it is a dynamic disease. So the thoracic outlet syndrome is severed when there is an abduction or retroflexion of the arm. And this is something you should keep in mind when you do this positioning, that you are able to do these position maneuvers during surgery to make sure that when you provoke or you go into the provocation, that there is no residual compression. And here you see the harmonic scalpel. I'm really, really careful. I don't use that. I only use bipolar and scissors because you can go in there stepwise, and you can have a little bit more control, but this is schematic. So I used that because it very nicely shows the step-by-step parts of the surgery. But I only use bipolar and scissors to be careful in that. And you see that you have to go to the first rib, and then you really have to go low. It depends on the individual anatomy. If you have females who are thin, who have a long neck, then it is easy anatomy. But you may also have a little bit stronger people, or a little bit shorter people, neckwise spoken, and then that might be really difficult to go below the inferior part of the trunks. And be careful, because you might induce some tension on the lower structures. And this is seen in the picture L, I think, on the right-hand side, that when I started, I used a free run EMG to make sure when I have to resect the first rib and I have to go below the inferior trunk, and I potentially have to put in a runger in or something like that, that I have a free run EMG to make sure that I don't injure or harm the inferior trunk due to tension or pulling over there. So I brought to you a case sample here, and you see on the left-hand side that it's the first rib. Actually, it's not an additional rib, but you can see that the individual positioning of an upgoing part of the joint between the process and the first rib leads to a elongation of the T1 nerve root on the right picture. So this is a very nice neurography, and you see the upper trunk, the median trunk, and the inferior trunk with a C7 nerve root and with a smaller TH1 and C8 and TH1 nerve root, and the TH1 nerve root really elongates upwards and is dislocated by the positioning of the angulation of the first rib. So this is the intraoperative picture. On the left-hand side, to see a brachial plexus and the anterior scalene with a phrenic nerve on it. And then I zoomed in a little bit deeper, and you see that for the brachial plexus, you have to put in some loops to visualize the first rib there. But you see that if you dislocate the brachial plexus to go below, you have to be careful that you don't elongate too much. And therefore, I really still find the free-run EMG very, very important. And then you can go in with a rongeur and be careful to take out the first rib. This is just an intraoperative picture, but I want to have a take-home message, or to let you take home some messages. You have to do a 360 decompression, and therefore you have to understand the brachial plexus in 3D. You have to think of soft and or bony structures as potential hypomacleans. A free-run EMG may help you to secure the nerve function when bony structures need to be resected. The phrenic nerve has to be kept intact. And what we usually do is that we do a preoperative workup. We have to include the X-ray to know what the bony structures look like. What we like to do a lot is the dynamic ultrasound, because that shows us where the compression is in terms of provocation maneuvers. And sometimes we even do the MR neurography, and that helps us a lot for surgical planning. Thank you.
Thank you so much. It was such an excellent talk. I mean, I think thoracic outlet remains one of the most debated and clinically challenging topic in not just peripheral nerve surgery, but in medicine. And I think I loved how you showed that our anatomy, not just of the brachial plexus, but the dynamic anatomy between the neural structure and all the different structure, and your use of the aids actually are important in understanding and approaching these cases. And it was fantastic. Thank you so much. So I'm now excited to for our final talk and pass the floor to Professor Socolovsky. You're on mute.
On mute.
Mariano, you're on mute. You're muted.
Yeah, I think I'm done, right?
Perfect.
Yes, we can hear you now.
Okay, thank you very much. I'm sorry for I'm sorry for this interruption. I'd like to thank Damiano and Thomas for this kind invitation to speak about peripheral nerves, but also about the brain. Because if you are doing peripheral nerve surgery, and this is a webinar about anatomy, I think we all should take into account what's going on here in the brain, because there are many changes occurring there. So I'm going to turn off the video, the sound of my computer, in order to avoid bothering you with my video sounds. And let's take, for instance, a certain nerve transfer, phrenic to musculocutaneous nerve transfer. So there are things occurring there. I know many people do not do this nerve transfer in many places, and in many others it's very popular. So I just want to focus in the phenomena that occurs at the brain, because after nerve transfer, in an early phase, and you see that the elbow flexion is inspired by inspiration. So the patient, as you can see here in the video, breathes in very deeply, and then he flexes the elbow. This is at an early phase or an initial stage, and after that, the elbow becomes independent, as you can see in the second video, where the elbow flexion is completely independent, or let's say it's independent from the breathing movements. So that's what's going on at the brain. There are some changes occurring at the brain in terms of control, of voluntary control. So just to be very short on this topic, let's say that basically the original motor cortex for the biceps regain control in the late phase. In the early phase, the motor control is under the phrenic nerve motor cortex, but then there are changes occurring at the brain. So this is what's going on, and this is basically brain plasticity. What we call brain plasticity is the ability of the brain to change. But brain plasticity, I'm sorry to say this, is not perfect, and sometimes it's not even good. For instance, if you see these patients 10 years after the surgery, after brachial plexus injury, and what we did is spinal accessory to musculocutaneous. Spinal accessory, this means basically trapezium and ECM, to musculocutaneous. So look at the arrow and see how, in order to flex the elbow, the patient needs to contract the trapezium muscle. So this is not independent control. This is lack of brain plasticity. And so we've been trying to put numbers into this phenomenon and see what's going on in between different patients. And we create a basically all clinical scale, which we name plasticity grading score. And this is the score. It's a simple thing. It has only 4 steps, 1, 2, 3, 4, meaning 1, very bad plasticity or bad or voluntary control from the donor, and 4, which is wonderful plasticity, very good plasticity. So 1 to 4, it's easy to understand, and we correlate this with EMG findings, and they really correlate well. So let's put some examples. For instance, this patient needs completely to breathe in order to flex the elbow. He cannot do it separately. So this is a PGS1, mean bad plasticity. Then we have, for instance, PGS2, like in this patient, intercostal to musculocutaneous. He can flex, but when we ask him to breathe in very, very deeply, what's going on is in the second video on the right, you see that after a deep breath, he just flexes a bit. Why? Because, as you know, the intercostals are accessory for inspiration and also for expiration. So that's how the pattern reproduces, and it's completely different from the pattern we call this PGS2, not so well plasticity. And this is a completely different pattern than what happens when you use the phrenic nerve. If you use the phrenic nerve, during the whole inspiration, you will have the stimulus to flex. And you see here, in another patient, 18 years after phrenic to musculocutaneous, she has wonderful British Medical Council for elbow flexion. But when I ask her to breathe in very deeply, as you see, there is a contraction of the biceps, a subtle contraction. This is a very good plasticity. In fact, it's a PGS3. And then we have PGS4, which is very good independent, complete independent from the donor to the receptor motor programs. And this is what happens in this patient, for instance, after the double Oberlin plus SOMSAC tricep to axillary plus spinal to suprascapular. So this is a PGS4. And usually this happens in intraplexural nerve transfers. So we publish a lot on this topic, and as you will see, only only 18 patients, and this is important, only 18 patients get PGS4. Otherwise, most of them, this means 82% of our initial series, show other type of brain plasticity, meaning 1, 2, or 3. Brain plasticity, so it's limited in adults. And in fact, we can see differences in between the extraplexural and the intraplexural nerve transfers. The extraplexural, like the phrenic or the spinal accessory, the fibers come from different places. So that's why, as you see in the mean of the groups, the mean is much lower for extraplexural than for intraplexural. And this is a graphic explanation of this. It's logical because an intra-nerve transfer, like for instance, the Oberlin procedure, you need, in order to flex the elbow, maybe to contract the FCU. And this is normal. When you reach something, whatever you reach with your hand, you need to contract the elbow, but also to contract the whole limb. So that's why an intraplexural nerve transfer, when possible, of course, is much more logical in terms of voluntary control. By the way, different extraplexural nerve transfers are usually much lower in terms of plasticity. So there is an important, and again, we are in anatomy committee, and we are speaking about anatomy, but not only of peripheral nerve, but also anatomy of the brain, which is also important to explain our results. So if we move to the face reanimation, this is another interesting thing to mention, because you see the area of the face here, and you see after hypoglossal to facial nerve transfer, you see the patient before the transfer on the left and in the right. You see that this is a very successful procedure. We are very happy with this, and especially our patients are very happy with this. Not only for his T-shirt, of course, in this special moment, but also because he regained a lot of function, and in terms of social, psychological, laboral behavior, that's very important. But the face is a mirror of our limbic system. So whatever our limbic system receives, it goes directly to the face automatically. If you innervate the face with the lingual nerve, with the hypoglossal nerve, you won't expect spontaneous smile, for instance. And you can see in this hypoglossal to facial nerve, you see in this other patient also, you see the spontaneous smile is absent. Even having a good result of your surgery, you won't expect spontaneous smile. So we adapt our scale to the face, and we saw that the mean PGS for face nerve transfers is much lower than brachial plexus in both types of nerve transfer, extraplexural, intraplexural. It doesn't matter. Face always do worst. We published on that this year, and if you compare, these patients had, the two of them had face-to-face reanimation. They all had injuries to the facial nerve, and they all regained, both of them, they both regain spontaneous smile. This is facial to facial. If you cannot do it, because for instance, this is you have a vestibular schwannoma patient, then smiling after, and you have to warn your patient about this, after, for instance, hypoglossal, it's not this one. This is the patient smiling, but she's thinking of contracting the tongue against the hard palate, and that's how she gets this smile. But after a joke, you see, this is the real spontaneous smile. So plasticity after face reanimation is very bad if you are using a nerve, another nerve than the facial nerve. So it's all in the brain. It's a fact of the distance in between and the function in between extraplexual and intraplexual donors. But also, as you saw, there is a mean PGS difference. But also, not only the distance, also the area is involved. And that's an explanation why two near zones like hypoglossal or lingual and facial areas are very close one from each other, but at the same time, you cannot expect to remodel a big surface or a big area of the brain. That's why it is not only a matter of the distance from the donor and the motor and the receptor or the target area of your brain, but also on the complete area you want to reinnervate. And the same happens with the hand, where you have a big area. So there is an importance of the distance and importance of the whole cortical area involved in the reanimation when you are doing nerve transfers. So what? You can say, oh, very nice, Mariano, very nice. How can we apply this to our clinics? Very importantly, we should know about brain plasticity, or let's say lack of it, for your patient's benefit. Two small examples, for instance, to plan your surgery and also to plan your rehabilitation. How do you see your surgery involved in this? Because, for instance, if you use an agonist and an antagonist nerves, maybe the function, the regain function, will not be so good as the group from Brasilia by Marcio Mendoza Cardoso showed in this article. And as you can see, if you use, for instance, the pectoral to reinnervate the axillary, maybe the results of your surgery are not so good. And this is, in fact, what happened in this particular patient. Very, very successful in terms of rehabilitation, very successful in terms of elbow flexion, but the shoulder abduction was not so good. And probably this is because we use pectoral fascicles to reanimate the axillary. So when you are transferring a nerve, you are not just doing peripheral nerve surgery, you are also doing brain surgery in any way. And think about the original motor program of your donor nerve transfer. And again, we talk about rehabilitation, and rehabilitation is also important. And a close contact with your physiotherapist is very important. He or she has to know exactly what type of nerve transfer have you done, because in these videos you see that you need a specific rehabilitation. That's for sure. And for instance, in this initial stage of an overland procedure, of a double fascicular transfer, you see how you rehabilitate by flexing the wrist, how you rehabilitate your biceps. And this is a common thing. And this has to be considered by the patient, by the surgeon, and more importantly, of course, by the physiotherapist. This important information has to be known. So in rehabilitation, the step one would be to get the strength, and then to work on brain plasticity and to get the most independent that you can get from your targets. So my final conclusion would be, when planning a surgery or a rehabilitation after nerve injury, and you're using a nerve transfer, consider our knowledge, our present knowledge, and probably our future knowledge on brain plasticity. Thank you very, very much for your kind attention.
Thank you so much. Wow, this was definitely a thought-provoking, plasticity-enhancing talk. It was amazing. I think I mean, I truly believe that peripheral nerve surgery has advanced tremendously because of this collaborative nature with orthopedic, plastic surgery, rehabilitation. But at the same time, I think your talk makes very clear how the neurosurgeon remains key, have an essential role in brachial plexus and peripheral nerve surgery, because we have that holistic view. I mean, that is amazing. So at this point, I'll pass the floor to the chair of the WNS committee, Professor Santarius, to lead on the question and answer.
Thank you very much, Damiano, and thank you all the speakers for agreeing to speak to us and our audience. We're particularly excited that Damiano, through his enthusiasm and contact meant through, brings such a wonderful group of speakers, and Obviously, we all know that peripheral nerve surgery is a highly specialized work, and lots of well-established neurosurgeons will have very little knowledge of peripheral nerve surgery and even anatomy. So it's been absolutely fascinating for me, and my brain is buzzing how much I have managed to learn in such a short period of time, not only from sort of peripheral nerves, but also through the function in the brain. Okay, well, I'm sure other members of the committee and the wider audience will have lots of questions, so I don't want to take a lot of time. Petra, do you have any questions that have been set by the wider audience?
For now, not yet. I do see a lot of distinguished speakers in the audience as well. Perhaps if anyone would like to comment on the talks.
Well, just going from the beginning, Dr. Spinner gave us absolute tour de force anatomy of the brachial plexus. Dr. Binaghi showed us that radiology is not lagging much behind by other radiology, and actually I was amazed what you can actually directly see. Dr. Dengler took us through the thoracic outlet syndrome, which brought me back to my early training, which was amazing. And Dr. Socolovsky talked about plasticity, which I'd like to perhaps start with a question right there. Obviously, close work with the physiotherapist must be absolutely key, as it is in, let's say, plasticity with low-grade gliomas, which gain lots of popularity in this area. Do you have any comments on this?
Yes, I spoke about brain plasticity, but there are many other types of brain plasticity, including spinal cord plasticity. And this can be applied. That's why I think it's important to know this general knowledge about brain plasticity, because this can be applied very certainly to brain surgery and also to spinal surgery. So I think the brain has limits in terms of brain plasticity, but also there are many issues that can be disinvolved in order to get the best of your results. So that's how in brain mapping surgery, in gliomas, you have to keep the functions, but you will know that if you leave some tumor there, it's much better, because then the zone will regain control, or adjacent zones of the glioma will regain control, and then the general results of your surgery which will be much better. That's why I think this general knowledge of brain plasticity can be applied to any field of neurosurgery, and I really appreciate your question. Thank you very much, Thomas.
Thank you. Extrapolating from, again, low-grade glioma surgery and so on, do you think there's a role for TMS in sort of ushering or sort of stimulating plasticity in peripheral nerve surgery?
Absolutely sure about that. I cannot give you numbers, because we've been studying plasticity after nerve transfers and using a clinical scale, as I said, but certainly TMS and of course many other techniques should be documented about how they impact the results. Also, there is a big difference in between young patients and older patients in terms of brain plasticity. And we well know that brain plasticity is much better in younger ages. And that's how we can explain the better results we can expect in this type of surgeries, any type of surgeries, after when we do these surgeries in younger ages patients. So that's how we can apply this knowledge in many ways. And yes, of course, TMS is one.
By the way, I don't want to be dominating this question session. I have unlimited number of questions going, having listened to all these questions. Radiology. I was until recently I had no idea that you can even image in any sensible way brachial plexus. And when I saw recently some MRIs, I was amazed, but they were nowhere near as good that Dr. Binaghi's presentation showed us. I wanted to ask sort of a specific question. How often do you get, let's say, anterior nerve root avulsion straight from the spinal cord? And with it related question, can you have the nerve root avulsion without any radiological signs of that? Or certainly the radiological signs that you presented?
Well, it depends when the patient comes. If the patient comes early, we're able to see everything because there is no scarring tissue. So it's very easy to see the nerves. And what is important is we use only one sequence, and the sequence is only 4 minutes. So if there is no, if we have movement because the patient is not calm or moves, then we can repeat it. So it's easy to see. Then we do reconstructions, and I think it's the best is to scan as soon as possible.
And when you say sort of early, is it up to, I don't know, 7 days, 5 days, 1 day?
Well, I remember in Argentina, I used to say this, and until I got a baby 1 day old. Then I started to say, okay, then we'll just wait until the baby is 1 month old. Or these are big babies. So when the baby is around 5 to 8 kilos. So with an adult, it depends. Depends because they usually don't have just an injury in the brachial plexus. They have more complexes injuries. So if the patient is in, let's say, within a month in conditions, then it's the perfect timing. When is not the perfect timing? When more than 6 months pass by. Then we are a bit late. We will have a lot of fibrotic tissue. And for us, that's really complication because the fibrotic tissue will cover everything and will not be able to say what is what. So, for example, if I need to choose, the patient is able to cooperate and the injury just happened 3 days ago, I prefer to have the scan then and not wait 3 or 4 months. Plus, 24 hours after the accident, we will already see the muscles, the muscle change. So we will have then direct and indirect findings. So when the patient is ready, we are good to go, basically.
Perfect. Thank you much. I saw Petra has a question there.
Yes, thank you, Tom, for the time. So also, again, to Professor Daniela, I'm very interested in the sequence of MRN that you mentioned previously, but I see that you said it requires a specific coil and a specific configuration for it to run. How is the generalizability of this for normal MRI machines? Perhaps there is a special sequence that we can use, because it's amazing. You said only in 4 minutes we get such beautiful images.
Well, I must say that the examinations are done by me. So I speak with the patient. I see the patient, so I choose the coil. When I need to see the roots, I will use a neurovascular coil like anyone. And all of the scans have the sequences. There are no secrets. All of the machines are able to do. You just need to adapt the sequences and adapt to not only the region of interest, but also the pathology. So when I see the patient, I see how nervous or not she or he is. And then when I see that I will have a limited time, then I start with the 3D for the roots. And then if I have movement with the other sequences, I basically, it's fine with me. I want to have the roots to be able to see, to say if it is avulsed or not. If the patient is very cooperative and everything is fine, has no pain, then I do the whole examination, and that takes around 15 minutes. But depends. I adapt everything to the patient. I adapt the sequences. I choose the coils. I do the examination myself, basically.
May I add a comment on that?
Absolutely.
Because we had the pleasure to have Daniela here in Argentina for many years. Now we miss her because she's in Germany. But it's the same thing that happens when you ask for a neurophysiological study, an EMG or whatever, and you ask the study to be done by a good neurologist. Then the neurologist will do the physical exam, have an idea of what to examine, to do the exam on, and then the exam probably will be much better and much useful than an exam done by someone who doesn't know or doesn't care what's going on with the patient. So the same happens with the artisanal work that Daniela has been doing, or handicraft work that Daniela, I know she has been doing.
To Mariano's point, I think the conversation actually has to be a conversation. So it's not just Daniela individualizing. I think it's the phone call between the surgeon and the radiologist. And Daniela knows my relationship with one of her mentors, Kim Amrami, who's one of my friends but colleagues in radiology. The conversation starts before the patient gets in the room so that I get the images that I want and even more. So it's tailored. And I do the same thing with neurology. I always tell people, and I have to be careful, that the surgeon has to be smarter than the neurologist, and that can get you in trouble. But in a way, it's true because we know what we're focusing on. So there are certain muscles that they wouldn't ordinarily do on a protocol. And in their short exam, they may not know exactly what Mariano's thinking about with nerve transfers or whatever. So you've got to make that phone call. So.
Yeah, and I very much appreciate Dr. Spinner's comment in this sort of age when we have lots of systems and lots of automatic requests and so on. We don't sufficiently speak to our colleagues, and I think that's where we're losing a great deal, because things can be optimally fine-tuned simply by proper conversation. I'd like to ask Dr. Spinner about intra-operative neurophysiology. What do you typically have in terms of setup when you sort of have, let's say, traumatic upper brachial plexus in an adult?
So it's a loaded question. In fact, when Damiano gave me the talk on brachial plexus anatomy, as many of you know, with some of the important work that Susan McKinnon and others are doing, the focus is on distal transfers. Many people are not doing brachial plexus explorations anymore because they're going distal. So when I was thinking of this talk, do I reverse the apple cart and talk about everything except the brachial plexus. So to your point, then, it really gets to that fundamental question. Are brachial plexus surgeons exploring the brachial plexus? Now, I do religiously for many reasons. Number one is I'm an anatomist and I want to see the pathology. In order to understand the reconstruction, I need to understand the injury, which starts with my history, physical exam, EMG, and imaging. And then the OR is an extension, and I want to understand it at that level. Now, to your point, which is critical, David Klein, I think, taught the world of the importance of intraoperative testing. And I always credit him, but I also get to the bottom analogy, which is you can't judge a book by its cover. So the nerve that I showed that recovered was a tremendously awful injury. And you saw the neuroma of the upper trunk, and everyone in the room was betting that that was going to be a bad book and a bad injury. And then to our surprise, despite excellent intraoperative, despite preoperative EMGs showing nothing, we got good nerve action potentials. And then based on Dr. Klein's work, we left it alone, and patient ended up with an excellent recover over the year and a half. So your question, every patient with a neuroma in continuity, I use nerve action potentials. It's finicky. You have to have a good team. So just like Daniela or your neurologist, you have to have reproducible people in the OR, because Dr. Klein was a master at it himself. He also had a technician who could find signals and pulses in people who didn't have pulses and were dead. He was that good. I would say that that's an art, and it's a lost art because people are now going to nerve transfers. That's a whole other conversation because, here, to Mariano's point about intraplexal transfers and use of nerves, the plasticity is a lot better using the native nerve, and there are more axons, etc. So every patient post-ganglionic gets nerve action potentials. To Daniela's point, if I'm uncertain about preganglionic injury and just part of our protocol, we'll use MEPs and SCPs. And then depending on the lesion, I may also use intraoperative EMG from nerve to muscle. I think it's important also to train your team even on minor cases, because otherwise the team is not prepared. Thanks for the question.
Thank you. And that was a brilliant answer. Thank you very much. I wanted to ask Dr. Dengler about the thoracic outlet. I mean, it brings me right back to my sort of early training. I did vascular surgery, I did orthopedics, and obviously neurosurgery. Do you much? We talked about this sort of talking to other people. Do you involve much the other specialities in planning your surgery?
Thank you for the question. I think it's an interesting one. I usually involve neurology. Why? Because I have the pleasure that I do have a neurologist who's doing the high-resolution nerve ultrasound. I already stressed that the high-resolution nerve ultrasound gives you the possibility to visualize the brachial plexus during dynamic actions, especially if you have provocative maneuvers which induce the symptoms. And sometimes it does make sense to have a image on the nerve when it is compressed. And I know Daniela also put people in the MRI like this, but this cannot be done everywhere. So, and also, this is an important point because I was confronted with that a lot. We had people who did not believe in thoracic outlet syndrome. So we also still have people who think that there is no such syndrome. And of course, if you have patients that suffer from pain and who have been misdiagnosed for long years, you have a kind of, let's say, phenotype, which makes it not easy. to, well, keep in touch with them and to think of it as a solely somatic issue. So you really have to keep that in mind. And what I like in that is when I bring in the neurologist who's very focused on the nerve ultrasound, he's a very good person who does ultrasound very well, but I don't have to do it myself. So I'm not biased. So if I have someone who have potential, like also a co-diagnosis psychologically or somewhat, I'm not biased by it. So I can rely on someone who's not into the patient's anamnesis, into the history, and he gives me a nice feedback on what he sees in the nerve ultrasound. So my most important person interdisciplinarily is the neurologist who does the nerve ultrasound in the thoracic outlet syndrome.
Yeah, thoracic outlet syndrome, I guess, unless we're dealing with some very extreme cases, is highly dynamic and sort of functionally determined condition. And I think we'll be gradually moving to more and more functional even imaging. When I say functional imaging, I don't necessarily mean what we mean by functional MRI of the brain, but also imaging in different positions and perhaps dynamically. We've had cases with jugular vein compression, where when one has, for example, very dominant jugular vein on one side and turning the head that way leads to complete compression of the vein. So imaging the person straight, turning head left, turning head right on CTV shows you a great deal, and I'm sure similar things could potentially happen in a thoracic outlet syndrome, right?
That's true. Exactly. That's what I'm talking about. So the ultrasound is good in there. And also if you have Daniela close, then you can put your patient like this in the MRI. But not everyone has Daniela close. So you have to come up with other solutions.
Can I quickly ask a follow-up?
Damiano, go ahead.
Follow up on this question is, I mean, as peripheral nerve surgeons, we have the luxury, but also the problem that we have access to the entire body. I mean, we operate from the tip of the head to the toenail. And while we are experienced and we know the anatomy where we're working, I think we should probably also talk about complications. Complications do happen. And what I want to ask to Dr. Dengler, about the other member in the panel, well, when those complications happen, what's your relationship with the other specialties? So when do you have that pneumothorax or that vascular injury or that massive incision that we do that doesn't heal, or how did you establish your relationship in your practice? And how do you deal with that anatomy that does have an element of uncertainty? Because of course our training comes from, it's different. We don't have that as large exposure, for example, for plastic surgeons on soft tissue, but definitely, of course, we go in depth. We got a great knowledge of the nerves, and on the side of that, we also add your relation with tendons and muscle. How do you do that in your practice in the different countries? Do you do yourself, or do you work with different colleagues?
That is an excellent question. Thank you. So when I started to perform thoracic outlet surgery, I was still a quite young surgeon. However, the German system may differ a little bit to the US system. So we are generalists. So I'm exposed to spine and brain surgery. And when I went into spine training, we also had, if you go retroperitoneal and you have some vascular conflicts. So we are actually trained in that too as peripheral nerve surgeons. However, when I started to do thoracic outlet surgery and I had compressed arteries in my pre-operative workup, I had a lot of respect because I knew that this is surgery which is generally usually performed by vascular surgeons. So I, of course, started to talk to my vascular surgeon close by. So when I would run into a conflict with a major vessel, so that I could call him and that he would not say, oh, you did not warn me about it. So I usually start that beforehand. And then I did a lot of surgeries, and you get a little bit more confident with that. And I luckily did not have any trouble in thoracic outlet surgery. That may be different when you go into a recurrency. So if there has been an operation before and you have some scarring, then you should be extra careful. And this is usually something where I call my vascular surgeon beforehand. I never had trouble in that in thoracic outlet surgery. I had one case where I was maybe too confident. I don't know. I thought it is just a tumor in the brachial plexus and a patient which had been radiated before. And I really ran into trouble, let me tell you that. And it was a thyroid carcinoma on the lateral brachial plexus. I've never seen that before. She was a patient with a history of 3 malignancy, and the thyroid cancer had not been one of that. So I did not expect to find it. And if you have tumor bleeding, that is a different bleeding than you usually have in other entities. And during the first surgery, I called the vascular surgeon already. We had a total control about the blood. And then the patient went into the wake-up center, and she had a nausea and vomiting after the anesthesia. And due to the vomiting, the blood control went off, and we really had an emergency, and we had to come in, put her tracheostomy, and go back in with a vascular surgery. So this was kind of my worst case, let me say so. And that teaches you. You had 10 years of easy surgery at the thoracic outlet, and then you have one major complication, and you are happy if you have a vascular surgeon who's your friend.
Many thanks, Petra. I'm mindful that we take other questions.
Oh, there are not. Is there any time for more?
See whether Damiano allows us.
I think Ramis should definitely close the session with his last question.
Right. No, I'm very fascinated with that. Yeah, I used to go to a course with Professor Spinner, and I will sit and listen to peripheral nerves. I don't do it. And the question comes about neurosurgical training and peripheral nerve. I have two questions. Is there need to recruit more trainees in the specialty? And how do you think that the different programs lack training? And the question will go again, Damiano and Dr. Dengler. How were you pulled into peripheral nerves, especially now the trainees subspecialize their knowledge. They no longer want to know anything that they are not going to subspecialize is. And as we can see, with the brain plasticity, you need to know everything, even if you don't know it. What is the current status of needing trainees to go into the specialty from neurosurgery? Is there a need to expand it?
We need, let me comment on this.
Mariano, you go first.
Need brachial plexus and peripheral nerve surgeons in the world. There are not enough people. So in my personal, and I know that Nora and Bob will agree with that. In my personal view, I see that more and more young people, including neurosurgeons, are interested in this subspecialty, which can recreate or restore completely lost function months after losing it. So there is an interesting way to sell to young people this specialty when you see the patient really recover. But we need to sell it. Certainly.
Because it's a part of the training, especially I know because I do vascular surgery, there are part of radiological anatomy that is lacking, like angiography. I mean, looking at the brachial plexus imaging, this is the surgeons will develop their 3D appreciation of the anatomy for operative anatomy better than anything, just to be able to interpret radiology as we have seen today is fascinating. The other question I want to ask about the brain plasticity, is there anything in the rehabilitation that can start to enhance the plasticity before the nerve anastomosis starts to work? Because preemptive.
Oh, That's a good question. And we didn't study that in a methodological way, but I assume that if you train the patient even before the surgery, which is not always possible, you receive a complex patient, the patient goes to surgery, it's not always possible. But I feel that if we do a special training on what you are planning to do or which nerve transfer are you planning to do, then the patient can understand the surgery much better and the rehabilitation. Of course, you can do it afterwards, and that's what we do in general. But in many ways, that would be interesting to answer in the future years. Thank you for your question.
Thank you. Thank you.
Damiano,
I think
yeah, I think
yeah, I can say good. Good. I would say just I want to thank everyone for the wonderful talks and the discussions, and I hope that everyone that has been online and everyone that's going to listen to the recording share even just a fraction of my fascination for this amazing specialty. I want to again thank everyone, all the speakers that mentor, colleague, and friends, everyone in the panel that has made this possible. And I hope that we're going to have another peripheral nerve webinar soon.
Well, thank you very much, Damiano, for organizing it, for chairing it. If I wasn't as old as I am, I would definitely divert and change into peripheral nerve surgery. Well, maybe
It's too
I'm
late.
still never too late. Okay, well, I have lots of potential fellowships to consider with all the panelists, and but I'm afraid I will have to compete with all the rest of the audience now. And again, thank you very much for joining us, and looking forward to the
Damiano,
next peripheral nerve.
there is one question on the chat from someone typed a question.
Okay, so I'll read out the question.
Yeah.
Damiano, do you want to read it out?
Yeah, I would say just Mariano, if you can give a quick answer to the question, I think it's for you, in your analysis and experience, what is the clinical predictor or intervention that could be done for a good recovery in plasticity?
Well, just to be short and very concise, because I know we are run out of time. And thank you for this question. I think there are many factors. We've been studying, for instance, the influence of a higher level of education and a higher level of IQ, of flow type intelligence in the results of brain of nerve transfers, and we saw a direct correlation. The higher IQ, the higher level of education, maybe are influencing the results. If you do another thing, if you do a nerve transfer on Lionel Messi, who managed his body, as we all know very well, probably your results will be much better because his intelligence in terms of sport intelligence, or let's call body managed intelligence, is much better. So there are many factors, including age, as I mentioned before, that can influence your brain plasticity. You have to be prepared of that and know that maybe older patients, maybe certain patients will perhaps do it not so well. This is because they are there, or their compliance much better with the rehabilitation or not. This is to discuss, and we should discuss this in 2 or 3 days, because this is a very important thing.
Okay, I think we'll have to finish here now. Thanks again, all those who joined, especially panelists and Damiano for putting together and chairing the section, the meeting so well.
Thank you, everyone. Bye-bye.
See you, everyone.
Thank you.
Thank you. Thank you.
You bye.